Hello and welcome. I'm Andreas Groll from the University Children's Hospital Münster, Germany, and I'm speaking today on behalf of the pediatric group on the pediatric part of the Global Guideline Candida diseases. Now, in pediatric patients, relevant differences in comparison to adults exist in the biology and treatment of underlying conditions and comorbidities, the exact epidemiology of invasive candidiasis, the performance of diagnostic tests, the pharmacology and dosing of systemic antifungal agents, and the availability of evidence. The pediatric section of the guideline addresses the populations at risk, the epidemiology of invasive candida isolates and outcome, diagnostic approaches including the role of the beta-D-glucan and molecular assays, the pharmacology and dosing of antifungal agents in children and neonates, general management considerations for invasive candidiasis, and finally recommendations for prophylaxis and treatment. The pediatric populations at risk of developing invasive candidiasis include premature neonates, critically ill children receiving treatment on intensive care units, children with hematological malignancies, allogeneic hematopoietic cell transplantation, and transplantation or complex surgery of intra-abdominal organs. Inherited disorders such as the CARD9 primary immunodeficiency also increase susceptibility for invasive fungal infections. The spectrum of invasive candidiasis closely resembles that seen in adults with a predominance of catheter-associated candidemia. Specific disease manifestations in neonates include congenital cutaneous candidiasis, hematogenous meningoencephalitis, and urinary bezoars. Candida albicans, parapsilosis, and tropicalis are the species most frequently isolated in most series. Candida auris is an emerging pathogen and notable for its nosocomial spread and potential resistance. Dissemination in children is observed in 10 to 20% of patients with candidemia, and severe sepsis and/or septic shock occurs in approximately 30%. Mortality rates range between 15 and 25% in most series and can be close to 50% in patients admitted to the ICU. Now, what is the evidence for diagnostic procedures? Of course, standard diagnostic procedures for invasive candida infections include blood cultures, and microscopic examination of appropriate tissue and fluid specimens, and imaging studies as mandated by clinical findings. For age and weight adapted blood culture volumes, we refer to tabularized recommendations of the CRINCO or IDSA-ASM. Otherwise, we have to say indications, validity, advantages, and disadvantages of these diagnostic procedures in pediatric patients equal those for adults. Beta-D-glucan testing from serum has a yet undefined threshold for positivity in pediatric patients, providing a poor predictive value for a positive test result, and therefore recent pediatric guidelines recommend not using beta-D-glucan testing as screening or diagnostic tool. Molecular-based diagnostic methods are accepted for diagnostics in sterile liquid specimens and can also be performed in frozen or formalin-fixed paraffin-embedded tissues. What are the recommendations? First, in the pediatric population, recommendations for most diagnostic procedures, including conventional methods such as culture and microscopy, PCR-based molecular techniques, and imaging, are similar to those for adults. Then, if molecular diagnostics are locally not available, specimens should be sent to an appropriate reference laboratory. And finally, in contrast to adults, beta-D-glucan testing in serum is currently not recommended for prospective monitoring or routine diagnostic use in pediatric patients. The principles for recommendations for prophylaxis and treatment. For this and for their evaluation of antifungal interventions, the group considered 4 components based on current concepts of pediatric drug development that have been incorporated into previous pediatric guidelines. First, evidence for efficacy from studies in adults, with the exception of prophylaxis in neonates, of course. Second, the existence of quality pediatric pharmacokinetic data and dosing recommendations. Third, pediatric safety data and, where available, pediatric efficacy data. And lastly, regulatory approval for use in pediatric age groups, as this reflects an independent and high-quality assessment of pharmacokinetics, safety, dosing, and indicated use. While the recommendations for children may not be different for those for adults, the selection of a recommended antifungal prophylaxis or treatment should be guided by points 2 to 4 if there is more than one option available. There are no pediatric-specific studies on prophylaxis of Candida infections in critically ill patients in the pediatric intensive care unit and children receiving liver transplant or other organs, and therefore recommendations for this population are derived from studies in adults. Similarly, studies supporting the efficacy of fluconazole, posaconazole, voriconazole, and itraconazole for prophylaxis in cancer patients and patients undergoing HCT have been mostly performed in adults. However, at least limited data in the pediatric settings have been published on the prophylactic use of mica, caspo, voriconazole, posaconazole, and the intermittent dosing of liposomal amphotericin B and micafungin. Regarding recommendations, whereas there are no general recommendations for prophylaxis for patients following kidney, heart, and lung transplantation, prophylaxis with fluconazole may be considered in ICU patients at high risk for invasive candidiasis and high-risk liver transplant patients. Pediatric patients with AML, high-risk ALL, recurrent leukemia, and those undergoing HCT should receive antifungal prophylaxis. Fluconazole prophylaxis should be used only if the institutional incidence of invasive mold infections is low, or if there are active diagnostic and therapeutic algorithms for mold infections. Fluconazole clearly is not recommended in the post-engraftment setting following allogeneic HCT due to the dominant role of mold infections in this setting. Recommended agents to prevent IFD, including invasive candidiasis, are posaconazole, micafungin, and with lower strength of recommendation, caspofungin, itraconazole, voriconazole, and various dosing regimens of micafungin and liposomal amphotericin B. A number of studies have shown the efficacy of fluconazole given in different dosing schedules to neonates at risk of developing invasive candidiasis, and this refers to extremely low birth weight infants less than 1,000 gram birth weight. In institutional settings with an incidence of invasive candidiasis of more than 2% and a low rate of fluconazole resistance. Various oral non-absorbable compounds such as miconazole, lactobacillus casei, or Saccharomyces boulardii did not demonstrate an impact on the occurrence of invasive candidiasis. For recommendations in high-risk neonates, i.e. the extremely low birth weight infants less than 1,000 gram, in institutional settings with an incidence of invasive candidiasis greater than 2% and a low rate of fluconazole resistance, fluconazole in various dose regimens is strongly recommended for prophylaxis of invasive candidiasis. General infection control is strongly advised, and neonatal ICUs that implement fluconazole prophylaxis should follow Candida species epidemiology and fluconazole susceptibility trends. And this is an example from the written guideline, from the various tables that you can find there. You see the population. This is the example for fluconazole prophylaxis in VLBV infants. Population at risk, the intention to prevent invasive candidiasis, the various interventions that have been studied in clinical trials, the strength of recommendation, the quality of evidence, the references, and important annotations to the interventions. Now, general management principles for treatment are similar to those in adults, and they include the prompt initiation of appropriate antifungal therapy, the identification of the organism at the species level and resistance testing of all invasive isolates, control of the predisposing conditions, surgical source control as appropriate, and the removal of indwelling intravenous catheters and other prosthetic devices. In all cases of candidemia, clinical evaluation of deep sites of infection, including an ophthalmological examination, is required. The duration of therapy for uncomplicated candidemia is 14 days after blood cultures become sterile and the patient has recovered from neutropenia if present. For tissue-invasive candidiasis, the affected site, the patient's response, and the resolution of predisposing conditions determine the duration of treatment, similar to adults. First-line treatment for children is with an echinocandin or liposomal amphotericin B, and this is strongly supported for pediatric patients with invasive candidiasis, regardless of the underlying disease, the neutrophil count, and hemodynamic parameters. The safety profile of each agent needs to be considered for the individual patient. The use of ABLC and conventional amphotericin B is only moderately supported due to the potential for nephrotoxicity and infusion-related reactions. High-dose fluconazole at a dose of 12 mg per kilogram daily is recommended for switching to oral therapy in stable pediatric patients with susceptible Candida isolates, and voriconazole is not recommended due to the complicated pharmacology of this agent. Neonates, liposomal amphotericin B, conventional amphotericin B, and the echinocandin, caspofungin, and micafungin present comparable efficacy and are moderately recommended for invasive candidiasis. Fluconazole, with a loading dose of 25 mg per kilogram on the first day, is supported only in neonates with no prior exposure to azoles and in places with low level of fluconazole resistance. For hematogenous Candida meningoencephalitis, the optimal regimen in neonates is currently unknown. 3 randomized trials in cryptococcal meningitis provide an evidence-based foundation for the combination of conventional amphotericin B and 5-FC or flucytosine against other susceptible yeast infections of the CNS, including hematogenous Candida meningoencephalitis. Other rational options supported by bridging PK/PD data from an animal model of hematogenous Candida meningoencephalitis is high-dose micafungin. Of course, for monotherapy and the combination therapy, conventional amphotericin B can be replaced by liposomal amphotericin B. For neonates with Candida bezoars, a combination approach of treatment with systemic antifungal agents Surgical evaluation and source control is strongly supported. Options include here fluconazole and conventional amphotericin B, as they achieve both adequate exposures in the urinary tract. Again, an example here for neonates, congenital cutaneous invasive candidiasis, and neonates with Candida bezoars. You see the population on the left side, the intention, i.e. to cure the infection, the intervention, the strength of recommendation, the quality of evidence, the appropriate reference, and annotations if needed. Now, for salvage treatment, no clinical trials have been performed in the setting of second-line or salvage therapy of invasive Candida infections. Strategies in patients with persistent blood cultures or refractory infections of sites other than the blood may include meticulous source control, including catheter, plastic removal, drainage or surgical removal of infected tissue, change in class of antifungal agent, i.e. replacement of an echinocandin by a pollen and vice versa, and combination therapy, pollen plus echinocandin, the addition of flucytosine to a pollen or echinocandin. But there is no grading because of the absence of data. With this, I'm at the end of the presentation of the pediatric part, and I sincerely thank you for your attention. You will find a complete text and all the tables, including dosing recommendations for children and neonates, in the full version, that you will find in the supplementary appendix of the guideline, and the pediatric part in the supplementary appendix starts at page 150. Thank you again. Bye-bye.